Dr. Sexton, I am eager to get into the conversation today. But first, before we get into the conversation about migraines and concussions, thanks for joining me. I know you're busy, and so thanks for taking the time to chat with Invisible Condition about two very prominent diagnoses here in Canada and in the U.S.
Well, I'm a fan of your work, and also I think this is such an important topic that it behooves us as physicians to make time for it and to try and reach as wide an audience as we can, because lots and lots of people who are living with chronic migraine, one of the biggest issues is they don't get diagnosed, so they're not even accessing potential treatments.
Yeah, not even get diagnosed. We're going to get into that because that is, when I hear that, and I have friends who have various ailments and are struggling to get a diagnosis, and it breaks my heart. And, I'm doing some work in the self-advocacy space, and that's a broad topic and it's a hard topic, and it varies for everybody in a different way. But we're going to get into that a little bit. But let's talk about migraines. You do a lot of work with migraines, concussions, eyes, all sorts of stuff. But let's just talk about migraines. Why don't we just provide a definition and what you have seen with your patients?
So I think the important thing is most people will have a sense of what a migraine is. And most people who are listening will think of it as being an acute headache that occurs episodically, that puts people on the floor in a dark room, sensitive to sound, sensitive to light, nauseated, generally thought to be only on one side of the head, and generally lasting for several hours. And that is a good definition of an acute episodic migraine, but that's only one of many, many forms of migraine. And the one that I end up treating most often is what's called chronic migraine. Chronic migraine is characterized by having lots and lots and lots of days of headache in a month. It's not just one or two or a few days around your period, or migraine if you had an extra drink at the office Christmas party. These are people who are living with severe debilitating headaches up to daily. And these guys are really sick. They are sick enough that if you give them quality of life scales, they rank themselves as ill as somebody who's had moderate to severe stroke or somebody who has to have chronic daily dialysis for kidney failure.
Wow. So I have experienced that acute migraine, and I could tell it happens every couple of years. I don't know. Maybe we could talk about why are migraines caused. It comes on, usually it's my left eye, and it goes, I lose my vision, and I know something's coming. But what causes it? Is there known causes for migraines?
So migraines described as what's called a neurovascular headache. And sometimes they're just in your DNA, bad luck. Sometimes they're caused by triggers, and triggers work a few different ways. I mean, you're a smart guy. If every time you had a glass of orange juice, you got a migraine, you'd figure out not to have a glass of orange juice. But migraines can be multifactorial. So maybe you're okay to have a glass of orange juice, but not on a day when your blood sugar is really low because you haven't eaten lunch and it spikes it right up high, and that causes the migraine. Or maybe you can have a cup of coffee, but not on a day when you're hyper stressed and you didn't sleep well. So one of the first things I encourage anybody with migraines to do is to keep a diary. Because quite frankly, if you get them every couple of years, I don't think you're going to remember that you had a ham sandwich on the same day 2 years ago. It's just putting it into the phone of what happened that day, how you slept, how you were feeling. Lots and lots of common food triggers. And so we talked about, trigger could be obvious, what we call kind of dose response. Trigger could be multifactorial. Things could be okay on some days, but not others. But the other kind of classic example would be somebody who's put on a new medication. And the most classic example would be birth control, because hormones are hormonal. And so somebody goes from having 2 or 3 headache days a month till 10 headache days a month. And a lot of times they don't think about being the medication because, well, it's 10 headache days a month. It's not 30 headache days a month. And I take the pill 30 days a month. So that's where the trigger acts to lower your threshold to have a headache. So you get them more easily than you did without the presence of that trigger. So when I'm giving patients triggers, things like nitrites in food and nightshades and processed food, I say, you got to pull everything like that out for at least 3 weeks to see if it's playing a role in your headaches or not.
3 weeks. Yeah. Someone who lives with Crohn's disease a food journal and knowing it's not just food, it could be other things.
Absolutely.
Right? It could be stress, it could be sleep, it could be you name it. And keeping that all in your mind of trying to remember everything is so that's really important. Jot it down.
It will, and especially, I mean, I've got patients who get weekend migraines, and it's because they've changed their sleep schedule. And migraines like schedule and they like routine, and they don't like it that you've decided to sleep in until 9 o'clock instead of 7 a.m. So sometimes we get rid of their headaches by having them get up at 7 a.m., walk around for 15 minutes, and then go back to bed and enjoy their lie-in.
Wow, really? So it's on. Wow, I did not realize that.
Lots of visual triggers. I've got patients who reliably will get migraines if they're scanning rapidly on a grocery store aisle under fluorescent lighting. Patients whose migraines will get set up by watching the columns of a bridge flicker by, or by dappled light when they're mountain biking and the lights coming in and out of the trees. I mean, they're pretty beastly.
Yes. Well, I'm really curious. I've had friends, not myself, but I've heard this secondhand, third hand, people going to a doctor and saying, "Hey, I've been battling bad headaches, migraines." And I've heard and I've had friends who weren't believed by their doctors. How do you even describe this, right? If it's debilitating, whether it's an acute episode or something that's more chronic, how do you approach your doctor and say, "Hey, this is what I'm living with"?
I mean, I would say that one of the issues is because we think of migraines, and even a lot of really good GPs think about migraines as being acute and episodic. That certainly is what I would have known about when I got out of medical school. Um, that when they hear the headaches are daily, migraine just doesn't pop into their head. So part of it is we need to educate our doctors better. They can't know everything. My dad was a GP. It's an incredibly broad field. So the estimate is that 1 in 40 Canadians, about 1 million people, are living with undiagnosed migraines. And I don't think that they're walking into their GP and saying, I have chronic migraines, and the GPs are saying, no, you're not. I think that is one of the issues. And then the other way it gets missed, and I see this all the time, is I've got patients who get headaches every day that are maybe a 3 or 4 out of 10. And so in my world, that's a low-grade migraine. If they also get 5 or 6 days of super painful headache. And what they want the GP to do is fix the days where they can't function. So they minimize or underestimate the days where they can function, because they want the attention to be on fix the thing that makes my head feel like I'm going to explode. And so they get to me and I take a comprehensive headache history and I go, oh my gosh, you're actually having headaches every day. Oh yeah, but, and right again, jump to wanting to only talk about the ones where they can't handle it. And then saying, no, we got to back the truck up. We've got a lot more to talk about here. But I do think, like you said, keeping a headache diary, looking for triggers, going into your GP with a month worth of data to say, this is how often I had a headache last month. And to make sure that's the reason you're there. That's what you want to talk about. It's not a sidebar to, the fact that you happen to have a sinus cold or you're worried that you've got a chest infection. And I think if you're still having trouble, you may say, like, look, you're so good at so many things. That's why I'm a GP. But, do you think I could benefit from seeing a headache specialist? Like, could we just get an extra set of eyes on this?
Mm-hmm. Yeah, I was recording with a doctor. We've released the episode months ago, and so I was talking about second opinions, asking for that second opinion. And what she said was really struck me was most doctors, right? If they don't know, they will send you to that specialist. If they are confident in their diagnosis, they have no problem sending you for that second opinion. It's when a doctor's saying, what, you don't trust me or you don't believe in me, that's when you should be like, okay, maybe I need to push for this. But what I'm hearing you say is like asking, right? Keeping that journal. And I've heard this for even all the self-advocacy questions I've been asking people is write it down, bring that to your doctor, present it and say, here's what's going on. And don't discount those quote unquote good days. When the pain's at 3 or 4, I know this with arthritis. I see my specialist soon and she's going to ask, how are you feeling? And it's like, well, today's a good day, but 2 days ago I couldn't walk, but today's a good day. It's focusing not just on that one day, but over that collective period of time.
And I think, one of the things that's worth noting is from the patient health and well-being perspective, by only focusing on the days you can't get through and minimizing the days you can, you are doing the best thing you can to look after yourself by being positive and finding the good and doing all the things we'd encourage you to do. It just doesn't help us as your doctor to figure out what's going on.
Yeah. Yeah, you're absolutely right. If you just go to your doctor and say, "Oh, today's a great day," but you discount those other days, it doesn't make your job any easier, does it?
No, and to add to the idea of asking for a second opinion, I'd say a couple of things. And the first thing I would say is that it is all about how it's not that I'm second guessing. I'm just wondering, could there be a new treatment that, you're on top of a million other things and maybe this neurologist would know about that you haven't yet? Like, is there any way that I could just go once and get some questions answered by somebody who sees a huge number of patients with this type of condition? And certainly for anybody who's listening who has concussion, I would say that at a baseline, excellent, brilliant GPs don't get training on how to treat chronic migraines. So a lot of them don't know how or aren't comfortable with some of the medications, and that's said with a lot of respect. But the second tier is, I have all these patients, and I mean, this happened to me when I was first really treating a lot of patients with migraine. I would think about the migraine patients one way and the concussion patients with headache another way until I kind of went, wait a minute, these guys walk and talk and behave just like my migraine patients. They just happen to have the problem start after they hit their head rather than, when they hit their period. And how are these two different subtypes of patient? And there seems to be very, very few practitioners who are aggressively treating post-concussive headaches that last past the 30-day mark the way that they would treat chronic migraines, even though, as I said, they both walk like a duck and talk like a duck.
Well, it's a great segue because that's concussions is something I'm passionate about. I've never experienced. Well, I was actually thinking about this weekend. Have I experienced a concussion? And I can think of one scenario where I had a terrible accident, and I'm sure I had some damage. There's something going on, but I never sought medical attention for it. Is there an overlap? As you said, there is that overlap between migraines and concussions. And how have you seen maybe a misdiagnosis or how does that overlap? How is that prevalent in the work that you do?
So I would say I'm going to start with just some definitions so everybody's on the
Yeah,
same
that's a
page.
good place.
So the first thing is you can have chronic headaches after an accident and not have a concussion or mild traumatic brain injury. You can have something called chronic post-traumatic headaches, where the headaches are started by the accident. The accident's the cause, whether that's a sport accident, motor vehicle accident, you banged your head on a top shelf in your house. So you can have headaches without jumping to concussion or mild traumatic brain injury. But a lot of the presenting complaint is headache. People start to call it concussion. That's a dangerous rabbit hole for a lot of reasons. The first is when you tell people they have a concussion, then memory loss because their head is pounding becomes memory loss because they have a brain injury. Word finding difficulties because their head is pounding becomes word finding difficulties because they have a brain injury. So you can spiral somebody into thinking that they are sick for a different reason than they are. Concussion and mild traumatic brain injury is overdiagnosed. And the new diagnostic criteria for it are quite clear. And so to meet the threshold for that diagnosis, you have to have amnesia that dates back from the accident or for a period of time after the accident, a loss of consciousness, or something called an altered state of consciousness. And historically, before the new diagnostic criteria came out in May of 2023, people will go, how did you feel after? And you'd say, I was dazed, I was confused, I couldn't figure out what happened. Those are all normal ways to feel after you've been rear-ended by somebody going 80 kilometers an hour. That's not a mild traumatic brain injury. If somebody came into my office and said, I knew exactly what had happened, I was crystal clear on my thinking, and I immediately started to, track my ICBC claim in my head, or I knew that I'd been hit by this big linebacker. I remember, it's people, even like athletes, they get hit from nowhere. They get hit from behind. They're completely confused about what happened. But an altered state of consciousness is somebody who can't follow two-step commands, who isn't oriented to day or place, who, has an acute confusion or irrational anger. I know you pretty well. If you get rear-ended, you're not the guy I think is going to get out of his car, run back and start punching the person behind them in the face through the window. If you did that, I would diagnose that as an altered state of consciousness. Now, some of my other patients, maybe not. Maybe that's just a Wednesday, right? But for you, that's clearly out of character.
Yeah, interesting. So it's really that as something not just out of character, something that is when you lose that consciousness. And so you said, has concussions been overdiagnosed then, or has it been underdiagnosed?
I would say that concussion is overdiagnosed and is often retroactively diagnosed wrong. So I'll see somebody who didn't have anything other than headaches initially, and then, they get deconditioned. The headaches are bad. They're not going to the gym, so they're not in the same shape that they were. So pain is getting worse and not getting better. And as time from the accident, when they can't go to work lengthens, can't return to sport, can't do the things they love with their loved ones, often that causes very legitimate depression, very legitimate anxiety. Often they become progressively stressed. Sleep becomes progressively poor. So a year and a half later, they go into a doctor's office who's busy and doesn't have a lot of time. They say, "What happened after the accident?" "I got headaches. I stopped sleeping. I lost my memory. I got, and oh, well, that sounds like a concussion to me." And often at that point, the subtle details of, did you lose consciousness? Did you lose your memory? Or did you act in a really erratic way that you can convince me you were not yourself? It doesn't get captured. And until May of 2023, I could use the word concussion and not mean mild traumatic brain injury. So sometimes it was a slang term for people who had a lot of symptoms after an accident, but we didn't want to call it a mild traumatic brain injury. Well, now those terms are interchangeable. So you have to hit that threshold in order to get that medical diagnosis, which isn't to minimize people who have ringing in their ears after an accident, blurred vision after an accident, and all sorts of other symptoms along with their headaches that often are primarily headache related. And if you treat the headache, you treat the symptoms. You don't need to call it something that it's not.
Fascinating. So this just came out, this new diagnosis criteria in 2023. And I'm curious, have you had any uh, conversations with people about, well, I've had concussion, so what is this now? Am I getting undiagnosed, or how does that even work?
It's keeping in mind that concussion is one of the invisible diseases, right? It's incredibly sensitive from the perspective that the number one thing that somebody with chronic migraine or chronic concussion identifies as a fear is that people think they're making it up or they think that they're crazy. So some of the toughest conversations that I have are introducing to somebody that there may be a component of anxiety that's contributing to their headaches, because that doesn't invalidate that the headaches are real and they're awful and they're ruining quality of life. But if anxiety is maybe part of the barrier to the treatment of the headache, would it be worth exploring, just thinking about whether or not treating that might treat the headache? And it might or it might not. I don't know. But why wouldn't we try? And then, to tell somebody who's been diagnosed with a concussion, hey, the criteria changed. I know that a year ago when you said you were dazed, we took your word for it and we called you brain injured, but now dazed means something different. It's very invalidating. It's insensitive. And so I don't like to have that conversation unless I absolutely have to, because I have to put something down on a form or. But I'll try and frame it to some extent as good news. I don't think you did because of this, this, and this. And I think that the headache is the primary problem. I think that, and sometimes they've got really good insight. Like I'll say, how's your memory on the rare days you're not having a headache? Oh, it's good, doc. I say, so that's not what my brain injured patients tell me. That's what my chronic migraine patients tell me. So
Interesting.
yeah, and so it's a trust issue. It's how you have the conversation, and it's 100% making sure you don't invalidate the fact that this is somebody who's in pain and having symptoms after a trauma.
I love that you said that you don't want to invalidate someone. I couldn't imagine if after many years, my rheumatoid or my doctor said, "Oh, actually, you don't have arthritis." Like, okay, so we've been treating it with medication, with all this stuff, and now all of a sudden, like, yeah, you invalidate someone, but also then that you break that trust as well. So, I think from your perspective as a doctor, a medical practitioner, there's a lot of sensitivity that needs to go into having these like hard conversations, whether it is a diagnosis or a change of path or a change of direction.
Hmm. Very much so. And I think, it's something, as I said, that you can say, okay, well, they changed the diagnostic criteria, but it doesn't change what's happened for the patient for the last 3 years in any way.
Yeah, it doesn't invalidate how someone is feeling. Like if somebody said, "Hey Tim, well, this is you don't have X, Y, or Z," well, I still feel that way. I'm still struggling. I still have this pain. So now what is it? Let's go and explore that. Let's get to the root of that problem.
And it's interesting, you know, with that concussion diagnosis, a lot of times I will see somebody who's been very fit their entire lives. They're an athlete, they're a weightlifter, they're a runner, and the injury just knocks them out of all of that. And so they physically don't feel like themselves. They're more fatigued because they're not getting exercise, which often means they're not getting good sleep. Maybe they're not getting good sleep for other reasons. They feel like they're in a cognitive fog. They may have a little bit of depression, which is almost, I can't imagine if I woke up every day and my head was pounding and I had to give up my work, I had to give up my friends, I had to give up my activities, that even one of our most resilient individuals wouldn't have lower mood than they did before the trauma. And as I said, very difficult because as soon as you enter that mental health aspect, they think that you're saying there is no other injury, whereas they're saying, no, it's running in parallel here. We want to tackle both things. But, you know, one of the most evidence-based things that we know about concussion is that people who are able to actively rehabilitate it do better than people who passively rehabilitate it. But if you used to go to the gym, pick up the bench press and do X, or throw the treadmill onto Y miles an hour, and it was nothing, and now that makes you feel like you've been hit with a baseball bat. If you've never been out of shape in your life, you don't know that that's how out of shape people feel. That's not a concussion necessarily. It's how it feels when you don't exercise regularly.
It's so complex, isn't it? It's I don't envy your job. It's just so complex, and there's so many different factors that go into it, and that's hard, especially when you tack on migraines or concussion with you know um, some mental health stuff, or like you said, even in that example, like maybe your body is starting to get a little soft, and you're not used to that. It's got to be challenging.
I mean, I certainly feel more for the patients than I do for myself. But to your point, when I'm able to help somebody with chronic migraine or concussion, it's one of the most gratifying things I get to do. And I can tell you that it wouldn't matter with those patients. If I'm running half an hour behind, they're not going to, you know, yell at me. They're not going to. They know I'm behind because I'm trying to help somebody like them. And if they've been helped, boy, are they happy. I can tell when I walk into a room after I've done a medical intervention or a lifestyle intervention for somebody with concussion or migraine. If it's worked, I know before they tell me. Their face looks different. That pain mask is gone. You know, I would reliably say I can tell before they've opened their mouth 90% of the time if they're going to give me good news.
Wow.
And you and I were talking offline about, you know, how do you deal with the challenge of treating it? Because there are real significant barriers to treating it. And I don't know if you want me to get into that a little bit.
Yeah, let's do it. Especially I think it's a good segue because you highlighted this that this is an invisible condition. It's but also I like how you said you can walk into a room and you can see that pain mask, whether it's on or it's off. So yeah, let's go there.
So, I mean, I would say that the first thing, again, that's important is treating the patients where they are. So if somebody's been living a pretty miserable life and I start talking to them about lifestyle, which is always where I stop, and they're like, yeah, but I need something to help me now. Like, I'm ready to stick a knife in my head. We'll jump there. But generally speaking, I would say, especially practice in Kitsilano and British Columbia, Vancouver, you know, and a lot of my patients are female, and a lot of them are wary of overprescription, and doctors are jumping to their pill pads. So I will always start with lifestyle modification. Uh, Supplementation, very basically, with vitamin and minerals have been proven to reduce migraine and concussion symptoms in about 1 in 5 or 1 out of 6 individuals, which is a lot. Powdered ginger, just a teaspoon of ginger like you'd use to put into baking, in a third of a cup of water can be more effective than Advil or Tylenol in about 1 in 5 or 1 in 6 patients to get rid of that acute pounding headache when it onsets. Taking out the list of triggers that I send them, monitoring for things like stress and sleep, trying to get into better routines, trying to incorporate some form of exercise. Again, do I fix a lot of people with it? I don't, but I fix enough that then they don't want to go on medication because life's tolerable again or even pleasant. or they tinker with it for a while and come back to me and say, okay, I can't get any further with lifestyle. Now, what do we do? But generally, I'll tell them everything I know how to and work with them until I hit the wall where I don't know anymore about how to modify lifestyle to help them. At which point, I like to have a conversation about medication. And medication, when it comes to migraine, falls into two categories. They have what we call our migraine abortifacients, meaning something you would take as the headache started to stop the headache from getting worse or to make the headache go away. That would be appropriate for somebody like you who gets a headache every day or two. But a lot of those medications, like Tylenol, like Advil, they're hard on our organs. They're hard on our kidney and liver. You don't want to be taking them every day if you have daily headache or multiple times throughout the day, which some of my patients do when they have this type of headache. And there are safer alternatives, much safer alternatives. Those fall into, there are a few of our rescue or medications, or abortifacient medications that are prescription. And there are a large number of them that are designed to be what's called preventative, where it's a pill you take every day or an injection that you receive monthly or every 3 months that is intended to cut the number of headaches down by about 50% and to reduce their intensity by about 50%.
Yeah, medication, I know, even for myself, it can be scary. But I like how you said you start that lifestyle because, as somebody who myself, I live with Crohn's disease. If I went to my doctor and was complaining that I'm always in flare, but I just eat fried food for 3 meals, 6 meals a day, well, I know my doctor will say, well, we gotta look at your lifestyle first. Let's get that under control. And medication doesn't have to be scary. And I think, and maybe, I don't know if you'd agree with me or not, I think as a patient, it's to understand, what is that medication for? What are the risks? Like, I have to, as a patient, be able to weigh those pros and cons and be able to say, make an informed decision myself. Because you take that medication, you go to the internet, you search it, you Google it, whatever you do, and it could be scary, right? I'm on a medication and I do my research and it's going like, oh, I'm going to die, like 100%. That's what the medication, and then I actually get to the real sites about the medication or just some objective opinions, and it's like, okay, it's not that scary. But how do you handle that with patients?
I mean, I think the first thing is to talk about the risks. And it's interesting because if you go on the internet and you type in any drug, I don't care what it is, I don't care. All of them cause blurred vision. That's the nightmare of every ophthalmologist, right? Anytime anybody's started on something new, they read on somewhere that it's going to cause blurred vision. They want to check in with me. Am I safe to start it or not? And the actual fact is, when people are listing side effects, they'll often have to list anything that happened during the study, whether they thought the drug caused it or not, which is different than the true side effects of the medication. So try and make a point of that. I also have to address a really common misconception that the headaches are masking the problem and they're hiding what's really going on. In actual fact, in experimental settings, we don't have an ability to do it. If you come into my office, I can't give you a blood test for it, but in experimental settings, when we go into the brain of migraine people, they have abnormally high amounts of a neurotransmitter called calcitonin gene-related peptide, or CGRP. And that's a neurotransmitter that makes your head hurt. Or if it goes to your nasal tissue in your brain, your olfactory center, it might make you smell something that's not there. If it goes to your visual cortex, it might show you pictures that aren't there in one eye or both eyes. And it's all this neurotransmitter. So the drugs that we know work, some of them lower the level of that neurotransmitter. So they're actually working the same way as our dopamine agonists do for people with Parkinson's who don't have enough dopamine, for serotonin boosts from our selective serotonin reuptake inhibitors for people with depression. And so the drugs aren't hiding things. They're actually trying to heal things. So that is a big open door for a lot of people. Some of the older medications that we use that are ordinarily wander around in life as seizure medications or hypertensive medications for people with high blood pressure, I think we have less idea how they work, but migraine's often viewed as a neurovascular headache. So controlling how fast the blood pressure can spike and how fast the heart rate can spike is likely naturally modulating the migraine response for some people. So I try and educate. It does take a long time. And a lot of times That's why I want to start with lifestyle, is if we don't have to have a half an hour conversation about what medications that you may go on 6 or 12 weeks from now when you're going to want me to repeat it all again, let's do it then. And sometimes we don't need to.
Yeah, well, I love that you start there, that lifestyle approach. And, somebody's listening to this, maybe you're just looking to educate yourself on this topic, or you are struggling to advocate for yourself. I think there's some good takeaways here where, write stuff down. But also, if your doctor maybe is just jumping straight, here's a prescription, see you later. Maybe pause and just ask, what are the side effects of this? What is this going to do? Is there somewhere else we could start? Maybe lifestyle, like what should I be looking at? Should I see a specialist? How can I see a specialist? Just even some of those quick questions, I know even for myself, have been incredibly helpful and have gotten me to the care team that I have now, which is a phenomenal care team. Didn't always have a phenomenal care team, and it took a lot of time. Which when you're suffering or struggling, it doesn't feel like you have time on your side, and so it takes time and to get diagnosis, to get the treatment, and so just don't give up.
Well, and then the other barrier that I haven't talked about is the cost of some of these medications, and it's a real barrier. Some of them are not covered by drug plans. Some of them are not covered by provincial drug plans here in Canada. Some of them, in order to access them, you have to try older classes of medication that are less likely to work and have more side effects first. So again, back to the trust issue, I've got a classic case would be somebody with concussion, and maybe they can't try some of the other medications. And I have to prescribe them something called topiramate, which I know it's nicknamed dopiramate because it clouds thinking. It makes some people feel cognitively foggy. Of course, it doesn't have that in everybody. So I've got to say to somebody who's walking around in a brain fog, all right, the only way I can get you the drug that I'd really like to try for you that I think would help you is to give you this other one for 30 to 60 days first that might make your concussion symptoms worse. You game for that? And so that trust of making sure they see what the long-term strategy is and that there is a long-term strategy is an important part. And when the drug does get turned down, I need to make sure that they come back and tell me about it. And I had 2 Olympic athletes, and they're under the same drug plan, and one of them gets approved for the drug and the other one doesn't, for the same diagnosis. And I call the drug company and say, what the heck? And they say, well, you didn't try this. I said, yeah, because you can't use it more than 9 days a month, and she'd be using it 60 times a month and kill herself. It's not on my table. Oh, okay, well then we'll approve it. Thanks, no problem. Right? And oftentimes it is just a clarification like that. But the patients sometimes think no means no. And if I've prescribed them something I think is going to be approved and I plan to see them again in 3 months, and they come back and say, how are your headaches so terrible? Oh, that drug didn't work. Oh, it didn't get approved. And I go, oh, how come? I don't know. All right, well, let's do our homework. Let's get to the bottom of this. And oftentimes we are able to either reverse it or put them through the steps we need to get it approved the second time that we ask for it.
The thought swirling around in my brain is, I know we were talking about concussions and migraines, and I think there's just so much insight in this episode for people who are just trying to advocate for themselves, right? I've had medications not approved by drug plans, and then I think, how am I going to pay for this? This is thousands and thousands of dollars, and yet we're here in Canada, and we have a different healthcare system than other places in the world. But still, like, just because we have a federal health plan, it doesn't mean everything is covered. Medication I'm on now, I am grandfathered into this program because I was one of the early people in this plan. I could not afford this. I'm a solopreneur. I don't have health. I don't have my own private health care. This would have cost me over $10,000 to $20,000. I can't get an exact price every 8 weeks. How can I afford that? And so when it's not approved, again, it's, what do? We need to take that back to our doctors. We need to say, hey, what can you help me with? Is there something else that I can get approved? Or, hey, I heard that this is going to work, but now what? There's options. And what I've heard from people who are trying to advocate for themselves is we hear no, and you hear that no a few times, and it's hard. And a friend of mine who was struggling with living with migraines for many, many years, had heard no so many times. And they just were like, I'm not giving up. And got the treatment. I'm going to record with her and release that in a few months. It's going to be a fascinating conversation because their journey of self-advocacy to get that diagnosis, to get that procedure, to get the medication, it's changed their life. And so have you encountered, what would you say to someone who's really now at that point where I don't know what to do? Maybe work doesn't believe them. Maybe they're struggling to get that treatment. What advice or what would you offer that person who is struggling in the context of maybe the work that you do in migraines and concussions?
I mean, I think one of the things that is helpful is, of course, making sure the patient knows you believe them. And one of the things I'll say often is I'm going to start giving out green wristbands, like those yellow Live Strong ones, so people can see that you're really sick. And I've endorsed the fact that there is a serious illness there. And then if there's a treatment reluctance specifically, I try and tackle it head on. And oftentimes I think it's them thinking about what the medication might do for them and their body, which is incredibly valid, but also to step the picture back and go, are there other aspects that we aren't considering here? Like when you're missing your son's hockey games because the arena's too noisy, or you're missing your daughter's, hockey games because there's too much motion or artifact on the ice and it's making you feel sick. Like what would your daughter want here and your son want? They want mom back. And if I think I can give mom back, isn't that worth taking a shot for? And so sometimes it's just broadening the perspective. Sometimes it's addressing the fear. Botox is an on-label treatment for migraine in Canada since 2011, and I treat a number of patients with it. And when I was first treating, it was somebody whose headaches went from debilitating 15 days a month to 0. Now, that's not a common response. I'm not trying to say that that's what people should expect. But for that individual, the impact on her quality of life was a miracle, in her words, not mine. She went back to her family doctor, who said, oh my goodness, they're putting Botox. That's going to take 10 years off your life. You got to get her to stop that. And she said to him, I'll take it. If I was told absolutely it would kill me 10 years earlier, but I can live the next however many years without headaches, deal. And so I think that's an interesting one. And in terms of advocacy, when you talk about patient support programs, I was giving a talk for a group of concussion specialists, and they were really taken aback by the prices of some of the medications. And I was saying, well, there's a support system right now, there's this, there's that. And they said, well, why would I start them on it when I know they're not going to be able to afford it if the program goes away? I said, well, I don't make money decisions for my patients. I'm sensitive to the fact not everybody has money. I'm sensitive to the fact that even if you have money, $10,000 or $20,000 every 8 weeks is probably really a small percentage. But you don't know. You don't know if their parents have money. You don't know if their siblings have money. You don't know if they get if they get on the drug for 6 months, if they'll go to work and get a job somewhere specifically that's got good benefits that would cover it in the absence of it being covered by the government. So I never ever make a decision that somebody can or can't afford something, or it is or isn't for them. I want to make sure that that is their decision when they're this sick.
Yeah, it's presenting all the options, and just taking a step back into concussions and migraines, and specifically, in society, right? We talked about the invisible nature of it. It's you look at someone and go, oh, but they look fine. Well, it's just a headache. Just take some Tylenol, take some Advil. That's really hard to hear, and I know know I'm guilty of it. It's like, oh, just sleep it off, or and I've been on the receiving end of that. And so for someone who is specifically living with migraines, living with concussion, um, what would you say to someone just to help them articulate what they need for support, or what they're even going through?
I find that letting them know what we sort of opened up with, that they should share with their family that the quality of life of somebody with their condition is the same as somebody who's had a moderate to severe stroke or has dialysis for kidney failure every day. That could be a really helpful thing, because people understand kidney failure is really bad, and they understand that a moderate to severe stroke is really bad. So if their doctor is telling them they have the same quality of life as those people do, that is something their family and friends often can relate to in a way that they couldn't relate to it when they were trying to think about how they feel when they have a bad headache once every couple of weeks or months.
Yeah, I like that, and I like you brought it right back to the beginning where it's let's compare it, and you bring a very tangible comparison to this diagnosis that it affects so many people here in Canada and around the globe. And I think as we wrap up, I ask this question to everyone, and this is a big, hard. I think it's big and hard, but yet I am so. Yeah. Anyway, I love to get into it. The purpose of Invisible Condition is to end the stigma of invisible conditions. And I know I say this is hard because it's so complex. How can we do this? How are we going to do this? How can we take steps in society, in our workplaces, or families to end the stigma that often is attached to our invisible conditions?
I mean, I think, as I say, big piece of the puzzle is education. Educate our GPs, educate our emergency room doctors, make sure that concussion is not being under or overdiagnosed, make sure that chronic migraine is being diagnosed, make sure that when it's diagnosed, it gets treated properly.
Yeah, that education piece is it's so important, and I like how you said we need to educate our doctors, our emergency room physicians. We also need to educate those around us. Like you said, even if I was diagnosed with chronic migraines or concussion, how to even educate those around us. And that's something that I'm looking to do here, even at Invisible Condition. What does that look like? And there's so many great resources. I know you've got a blog as well. We'll put that in the show notes. And yeah, as we wrap up, I just really appreciate you coming on and sharing with us just the definitions of migraines and concussions. And we took a turn into that whole advocacy piece, and which is something I'm passionate about. And just even that story of two Olympians diagnosed the same thing, same medications. One was approved, one wasn't. And if that's where the conversation ended, that'd be heartbreaking. And it didn't end there. And they got the approval and went. I don't know who they are, but I'm sure they're doing amazing things. And so, any final thoughts as we wrap up, Dr. Sexton?
I just say to anybody who's living with it, first of all, I'm sorry. It's a really, really tough diagnosis, whether it's concussion, brain injury, or migraine headache. If your head hurts all the time, you're miserable. Migraine, again, is a really good website, very trusted in terms of their resources and recommendations. Lots and lots of lifestyle stuff there for people who don't want to start with medication.
And we'll have a link to all of that in the show notes. Every time I put together a podcast page, I have definitions, I have resources, I have a lot of information on there, because it's not just about recording an episode and pushing it out. It's about educating ourselves and our loved ones. I've learned a lot about migraines and concussions in this conversation. And I hope if you're listening that you also have learned something. If you have questions for Dr. Sexton, we're going to do something a little bit differently. Send them to me. On the website, on the show page, I'll just have a link, a contact us link on there. Send me your question. I'll forward those on to Dr. Sexton, because I know even for myself, I'm listening to this and I'm like, oh, we could probably record for another hour because I've got so many questions. But this leaves us at a good place. And so if you are listening and you love what Invisible Condition is all about, please tell your friends, your family, subscribe to the newsletter. It comes out every couple weeks. Subscribe to the podcast, share it out. That's how we are going to end the stigma, or one way we're going to help end the stigma. And so Dr. Sexton, thank you for spending time with us today. I really appreciate you coming on.
Thank you.
And again, for those who are listening, I hope you have a good one.